So hello students, in this video we'll be learning about opioid analgesics. So initially, before we dive into that, we'll see what is pain. So pain or analgesia is nothing but the unpleasant bodily sensation which will be usually evoked by either internal or external and noxious stimulus. You can see in the image here. Also, pain is usually it's a protective phenomenon. It protects us from the external damage that is happening. Excessive pain, it will usually produce apprehension and sweating, palpitation, rise in blood pressure, tachypnea and all. So in order to combat this, what can we do? So there comes the concept of analgesia, which means to suppress the pain. So the drugs which will cause analgesia will relieve the pain without affecting the cause. Without affecting the cause, even if the cause is still present, these analgesic drugs will be able to prevent the brain from perceiving the pain stimulus. So how are these analgesic drugs divided? So they are actually divided into three types, which are of opioid type, non-opioid or adjuvant analgesics. Opioid are also called as narcotic or morphine-like. Non-opioid also called as non-narcotic or aspirin-like. Other adjuvant analgesics, we have the anti-epileptic drugs and antidepressant drugs which we'll be using. So how are these opioid analgesics classified? These are obtained from the natural sources like poppy plant, which consists of morphine and codeine. And if we add the group of diacetyl, it becomes diacetyl morphine, or also known as heroin, which you'll be looking in movies for that drugs and all. And we do have 4 ethyl morphine, which is we have added the ethyl group to the morphine. And synthetic, we have Pethidine and Methadone. They look like twins. They look like a rhyming. So you can remember like that. And we have fentanyl and remifentanil. We have tramadol and tapentadol. So these are the opioid analgesic drugs. We'll see what they'll do. So opioid analgesics, they are usually dark brown resinous material which is obtained from the poppy plant, which is called as Papaver somniferum. And this is the brown color extract which will be taken up from the opium plant, which will be giving us, it will be consisting around morphine by 10%, codeine, thebaine, papaver and noscapine, and the brown color extract from the Papaver somniferum plant itself. So mechanism of action. These opioid analgesics will act on mainly 3 receptors in the body, which are mu, kappa and delta. So what do they do? If they act on mu, they cause analgesia. If you see, all the actions will be deteriorating, all the actions will be inhibiting. Respiratory suppression, it will do miosis, constriction of pupillary diameter, sedation, muscular rigidity, reduced DI motility, and it also causes dependence on the drug which we are consuming. One thing is euphoria, that happens also due to inhibition. We'll see how it happens to the inhibition of what. Also, kappa will look similar in actions with respect to mu receptors, except for the thing that it causes dysphoria instead of euphoria. If delta receptors are stimulated, they have all the similar properties, except for it has the pro-convulsant property apart from the features which we have seen for mu receptor. So here comes the morphine. It is an alkaloid drug. And how does it act? It acts mainly on all the 3 receptors, mu, kappa and delta, but mainly on mu receptor. What happens? It causes analgesia. How? It causes analgesia, and it also mainly relieves the deep visceral pain rather than the sharp defined somatic pain in the human. Also, it also helps in relieving the apprehension, the sweating, the palpitation, rise in BP, which comes along with the severe pain stimuli. These are all will be controlled with morphine. So people love to take it because it not only suppresses the pain, it also suppresses the extra symptoms which we'll be getting apart from the pain. So people will be taking, people will be fond of it, they'll be addicted to that. So how does it work? It works mainly at 2 points. One is the spinal level, the other being the supraspinal level. Thus, at the spinal level, it works at a place which is known as substantia gelatinosa. In this image, we can see this part is the substantia gelatinosa in the spinal cord. The morphine works here. Morphine and also the other opioid drugs will work here. What does it do? Usually, if there is any pain stimulus which is coming from the nociceptors from the outside, this will be carried out by the primary efferent neuron, which will be connecting to the secondary neuron, which will be carrying these impulses to the brain. This will carry the impulses to the brain. If we try to abolish the connection between this primary neuron and secondary neuron somewhere here, there will be no transfer of pain impulses to the brain, right? So that is what the opioids will do. Usually there are 3 substances which are glutamate or substance P and CGRP, which are the pain transmitters, which will transmit the pain impulses from the presynaptic neuron to the postsynaptic neuron. So this morphine or any opioid drug, if it binds to the mu receptor on the presynaptic neuron, the release of these neurotransmitters will be prevented by the prevention of calcium influx. Once the calcium comes in, all these neurotransmitters will come out. But now the calcium channels are closed so that the calcium won't come in and these neurotransmitters will not come out. Also they'll open up the potassium channels of the postsynaptic neuron so that this nerve will become hyperpolarized. All the positive charges are gone out so that this becomes hyperpolarized. So there won't be any transmission of pain from this first neuron to the second neuron. So if there is no transmission of impulses from this first neuron to the second neuron, there won't be transmission of pain signals to the brain. So this is what it acts on the spinal way. So what happens in the second way? We have two pathways of pain. One is the ascending pathway and other is the descending pathway. Ascending pathway carries the pain from the site of trigger to the brain. Descending pathway is usually suppress the pain. So what happens is at supraspinal level, there is a connection like this where this will always be releasing something called as endogenous opioids, which are endorphins, enkephalins and dynorphins. These will relieve the pain. These were the natural painkillers. These will be released from the neurons in the descending pathway of the humans. So not every time we need a painkiller but what happens is there is a neuron which is known as the intermediary neuron, which will always be inhibiting the transfer of these endorphins to the descending pathway. So what happens is when this morphine goes and binds to this inhibitory neuron, this action of this inhibition will be gone. Therefore, when this action is not there, the impulses from the endorphins from the neurons above will be transmitted to the neuron which is on the below, so that the descending pathway will be active then. Once if the descending pathway is active, it will suppress the pain, which is a natural pain suppression process. So till then there is a block over here, which is the intermediary neuron. This morphine will inhibit the action of this inhibitory neuron so that the inhibitory pathway will be active. In order to understand, if you buy a new remote, there will be something called as a small paper or a piece of cardboard, so that the batteries will not be in connection with the actual circuit. Once if you remove it, once if you pluck it out, the batteries will start a complete connection with the remote and it starts working. Similarly, if you remove these inhibitory neurons, which are always inhibitory in nature, if you stop this function of this inhibitory neuron, this will allow the inhibitory impulses to start from the above, it goes till below and it goes and suppresses the pain. So ultimately morphine is now acting at two places, one being at the spinal cord level at the substantia gelatinosa. Morphine is acting over here, which is the first place, and it is also acting supraspinal level over here, this is the second place. So these two combinedly will cause a drastic pain reduction, so both the levels, by acting on both the levels. So what does it do? Always remember, bring it down. This is morphine, its only activity is to bring it down. Sedation, it causes sedation, and it is not like the other serious depressant, but it causes mild sedation when given. In respiratory center, mainly we have to see the respiratory rate will fall. It brings down the tidal volume also, and it also causes death if there is a morphine overdose. Cough center will be suppressed. Whatever the system you see, it will keep on suppressing it. Temperature center will be depressed, so that people, if they go to cold weather, the blood will turn cold, irrespective of because the thermostat of the hypothalamus will be shut down. And vasomotor center will be function will be lost, so that the vessels will become dilated and the blood will be pooling out in the systemic circulation, causing hypotension. So morphine will cause deterioration of everything, whatever you think of. There is a particular situation where it causes euphoria. Why? Because when people are with pain and with apprehension, this is found to be curing both. People will feel usually happy out of it, so they'll get euphoria. Also, if you give it IV, what happens is there is a same system which will be inhibited in the brain, but this will be releasing dopamine. Once if this inhibitory neuron is suspended, this neuron which is releasing dopamine will go and act, it will be releasing dopamine through the next neuron, so that the person will be having a gifted like state, or it'll be having the pleasure because of the dopamine which is released. So also it releases noradrenaline in the nucleus ceruleus just by inhibiting the inhibitory neuron which is in the nucleus ceruleus, so that these neurotransmitters will cause the sense of feeling of euphoria to the patient who is taking it. Also, if this morphine acts on the Edinger-Westphal nucleus of the third cranial nerve, it causes continuous triggering. It also inhibits the inhibitory neuron, so that there will be continuous triggering, continuous impulses which will be flowing, which will cause continuous constriction of the circular muscles of the pupil, which leads to the pinpoint pupil. Usually it causes miosis, but if it is overdose, it causes pinpoint pupil. Also, on the hormones, the FSH level will be reduced, LH level, ACTH level will be reduced, but growth hormone level and prolactin level will be increased because they will be under the inhibitory influence all the time. So that inhibitory influence will be gone, so that these hormones will be secreted more when you take morphine or opioids. CVS. So actually it causes vasodilation. It causes vasodilation by release of histamine in the body. Also it causes itching, and it depresses the vasomotor center as we have seen before, and by direct action on blood vessels, it causes dilation of the blood vessels in the systemic circulation. So this systemic circulation will be dilated, pulmonary circulation will not be affected. So what happens is the blood starts flowing into the systemic circulation more, and therefore the peripheral resistance will be less, the peripheral resistance will go down, and even if the heart is going through an ischemic state, this indirectly helps the heart to fight the ischemic state, because all the blood is now pooled in the systemic circulation somewhere over here, and there is no much pressure on the heart to pump it well. So during myocardial infarction where there is an ischemia, morphine helps in both relieving pain and also by pooling the blood in the periphery. On GIT, what happens is there are inhibitory neurotransmitters which are nitric oxide and vasoactive intestinal peptide. So this morphine will block it, will bring it down, will inhibit this action of relaxing neurotransmitters, so that the sphincters will no more relax, they'll become stiff. The muscles will no more relax, they'll become stiff, which ultimately leads to constipation. Also, the pyloric sphincter, ileocecal sphincter, anal sphincter, everything will get constricted, and it really leads to constipation. Also, if sphincter of Oddi, which is related to the gallbladder, occurs, this causes increase in the intrabiliary pressure and causes gallstones. So all the smooth muscles will get contracted, the detrusor muscle of the urinary bladder and the sphincter will also get contracted, causing difficulty in urination in older adult, usually in older people. So morphine will always shut down everything. Whatever the system you think of, remember, like, it will shut down. So what happens if morphine is given to a pregnant lady? This morphine can enter into the blood circulation of the baby through this way, and it will also enter into the brain because the blood-brain barrier is not that much formed in the baby. So it might cause suppression of respiratory center, and it causes apnea of the newborn. So it should be treated by giving the antidote which is called as naloxone. If you inject opioid antagonist naloxone into the umbilical cord of the baby will come out of the symptoms of morphine poisoning. So what happens if a person consumes morphine all of a sudden and there is acute morphine poisoning? The symptoms will be usually the same, which are like the pharmacological effects, but in an extreme condition. So the eyes will go into miosis, which we've seen that eyes will be found to be in a pinpoint state. Respiratory system, there will be all decrease of the respiration. There will be shallow breathing, lower respiratory rate. Cessation of the breathing occurs if there is overdose, and there will be death because of respiratory failure. So CNS, it causes sedation, and it brings down the threshold for seizures, so that it causes convulsions. And for CVS, it causes vasodilation. All the blood starts pooling there. There will be postural hypotension and shock which will be happening. So how to deal with this? So how to treat this? So first, if you bring the patient to the hospital, either the patient will be surviving because of the hypoxic drive which is already there, or hypercapnic drive. So if you try to give oxygen for this patient, his respiratory center, which is already depressed, which will think like the oxygen is retained and the respiratory rate which I'm working right now is enough. For example, if the respiratory rate is 5 times a minute, and if you give oxygen, the respiratory center will think like it is enough for the patient, so I'll continue throwing only 5 impulses per minute so that he'll respire only 5 times per minute, which is very deadly. So never ever give direct oxygen via mask to the patient who came with a morphine poisoning. So what to do? In this condition, we have to know that we have to be dealing with like ABC. So give positive pressure ventilation to the patient, and it might also clear the pulmonary edema if it is there, and maintain the blood pressure by giving some vasoconstrictor drugs, and do gastric lavage with potassium permanganate. Even if the morphine is taken by injection, you have to do gastric lavage by potassium permanganate and give the antidote. The acute morphine poisoning can be antagonized by giving naloxone 0.4 to 0.8 mg every 2 minutes till the respiratory center starts working normally. So this is how we'll be dealing with the case of acute morphine poisoning. So there is a concept called as tolerance. If a person is consuming morphine altogether all the time, so what happens is if there is more and more stimulation to the receptors, few receptors will go internalization and they'll be stopped from working. They won't work, and the few receptors which are left over on the membrane will only be working, so that the action will be reduced instead of giving more amount of drug. So this is called as the tolerance, morphine tolerance. So this is always seen, except all the features of the morphine will be seen to undergo into tolerance, except for 3 C's: constriction of pupil, which is miosis. No matter how many times you give morphine, no matter how many number of days you give morphine, constriction of pupil will never go into tolerance. And convulsions will always be occurring, constipation will also be occurring. Remember 3 C's, which will never undergo tolerance, in spite of giving the drug forever. There is a concept called as dependence. People who are taking it will undergo into a state of dependence, which will be causing if you try to stop the morphine from consumption from a patient who is already taking it for years together in a larger doses, it will cause the reverse of what the morphine will do, which is called as a withdrawal syndrome. It causes mydriasis, which is increase in the diameter of pupil, and it raises the blood pressure, causes increase in heart rate, sweating, tremors. This will be blocked if you stop the morphine from consumption to the patient. So now if you give antagonist, it also does the same thing of blocking the morphine action, so we should not give it. Rather, what we have to do is, there is a drug in the opioid class called as methadone. So what methadone does is, it also acts as an agonist to the opioid receptors, but it does not have all the adverse effects like morphine. So methadone is a long-acting opioid just to replace the morphine which is already consuming with the methadone, so that it will act on the opioid receptors. He'll feel like not consuming opioid anymore. So usually in infants or elderly, be careful while administering the drugs in respiratory diseases, because it will just suppress the respiratory center. You just make sure that the patient is not having asthma, COPD or cor-pulmonale or any disease related to the respiratory disease. In head injury, if there is a carbon dioxide retention and it causes vasodilation, patients with undiagnosed abdominal pain, because the morphine is constricting the sphincter of Oddi, so that it might cause the colic to happen. So just be careful while giving. Elderly male, it might cause some problems with the urination, so just be careful while giving. Other opioids apart from morphine, we have codeine. You might be seeing it on the most of the famous cough syrups. It has a least pain relieving analgesic property, but it is the best cough suppressant. So also it causes constipation. It is also used there. And we have heroin, which will be seeing in the movies mostly, that it is being illegally trafficking the heroin, because it is 3 times more potent than morphine. It gives more euphoria and it is more highly lipid soluble. And we have pethidine, it was actually discovered as an atropine substitute, but later on it was found to be acting on mu receptors also. The only thing is, it elevates the serotonin levels through its mechanism of action, so never ever combine it with SSRIs. It causes serotonin syndrome if you do that. Fentanyl, the most frequently used drug in analgesia, for its analgesic property in anesthesia, and it is 100 times more potent than the morphine. It starts working in 5 minutes and it works for 30 minutes. And it is most commonest used injectable in anesthesia. Nowadays we have transdermal patches which will be used for treating cancer pain also. And we have something called as methadone, which we have seen previously for the opioid addicts. It is useful as substitution for opioid dependence, and it should be withdrawn slowly once the patient comes out of the opioid addiction. And Tramadol, it acts via mu receptors just like the other opioids. Also it acts by inhibiting the reuptake of noradrenaline and serotonin. So this uptake of serotonin will be inhibited, so that the serotonin levels in the synapse will raise. If you give it with SSRIs, it will cause a serotonin syndrome. So remember, Tramadol will be most commonly used for people in orthopedic cases, and it will only cure mild to moderate cases which is of chronic pain. But with opioids, it is ultimately we can use them as analgesics, as pre-anesthetic medication for balanced anesthesia, fentanyl for pain relief, and for anxiety, relieving anxiety and apprehension, and for left ventricular failure, because the systemic blood will be more than the pulmonary circulation, cough will be suppressed, diarrhea will be treated because it causes constipation. A complex action of opioids, agonist-antagonist, we have, these are the drugs which will act on both mu and kappa, but they are more prone to be kappa agonist analgesics. So we have nalorphine and nalbuphine, which sounds the same, butorphanol, pentazocine. These are the other two drugs which will have mixed actions. There is one drug which acts as partial mu agonist and kappa antagonist, which is known as buprenorphine. So remember these names. And opioid antagonists, we have naloxone, naltrexone and nalmefene. So these are the drugs which we'll be using if there is an overdose or toxicity of morphine in the patient. So it blocks all the opioid receptors, naloxone, but the only thing is naloxone works only IV. Naltrexone can be given orally. So remember by this term, naloxone only the other way. Naloxone, there are two O's here, only the other way it has to be given. Enteric route is okay. Only remember these two, so that naloxone only the other way means it has to be given only and only IV. Enteric route is okay, it can be given orally. Naloxone and naltrexone. Naltrexone has longer duration of action. So initially, in order to make a person get rid of that opioid overdose, give IV dose first on the first day, followed by the tablet from the next day, so that it will act short but it will act quick. This will act long and it will act slow. So that's how you'll treat a patient with opioid toxicity. Thank you everyone. Thank you for your patience. Don't forget to like and subscribe to my channel.